Good afternoon. My name is Trisha Price-Smith, and today I will be presenting my Doctor of Nursing Practice Quality Improvement Project titled The Implementation of Educational Toolkits Upon Home Health Admission for the Reduction of Urinary Tract Infections. This project focuses on prevention-oriented system-level intervention implemented at the point of care on home health admission. The goal was to reduce UTI incidence among high-risk populations by standardizing education related to hydration, hygiene, symptom-based assessment, and antibiotic stewardship. I'd like to begin by acknowledging my DMP project committee. Dr. Maria Snell served as my project chair and provided mentorship through the design and implementation of this project. Dr. Boniface Stegman served as my second reader and supported methodological rigor. Dr. Jude Higgins served as my community member and contributed valuable insight related to population health and community impact. I also want to acknowledge Signature Healthcare at Home for serving as the project site and for supporting implementation during an organizational transition. The clinical inquiry question guiding this project was, in home health patients, does increased education on hydration and hygiene decrease the frequency of UTI over 3 months? This question was intentionally framed as a quality improvement inquiry rather than a hypothesis-driven research question. It aligns with a prevention-focused approach and emphasizes modifiable risk factors rather than reactive treatment after infection occurs. The question guided intervention design, outcome selection, and evaluation methods while maintaining feasibility within existing home health workflows. Urinary tract infections are among the most common infections in adults over the age of 65 and are particularly prevalent in home health populations. Patients receiving home health services face layered vulnerabilities, including dependence on activities of daily living, cognitive impairment, and homebound status. These factors limit independence, hydration, hygiene, and early symptom recognition. As a result, UTIs in this population are often predictable rather than isolated events. Beyond the clinical burden, UTIs contribute to functional decline, sepsis, and rehospitalization. From an organizational perspective, UTI-related hospitalizations negatively impact CMS quality measures and star ratings, which ultimately affect reimbursement under value-based purchasing models. UTIs are a leading driver of antibiotic prescribing in older adults. In home health settings, it's not uncommon for non-specific changes such as confusion or fatigue to prompt urine testing in the absence of clear UTI symptoms. This practice increases capture of ASB and contributes to inappropriate antibiotic use, resistance, and adverse drug events. The project addressed both patient safety and organizational quality by embedding stewardship principles into admission-level education. During the first quarter of 2024, the project site reported UTI rates of 2.59% of total admissions, more than doubling both state and national benchmarks. This discrepancy identified a clear quality gap. The needs assessment revealed that while regulatory education requirements were being met, existing materials focused primarily on broad infection recognition without structured prevention strategies or standardized diagnostic guidance. Clinically, dehydration-related cognitive changes were often misinterpreted as infection, leading to unnecessary urine testing and antibiotic exposure. Education specific to recurrent UTI was also lacking for patients and caregivers. These gaps highlighted the need for consistent, evidence-based education delivered at a critical transition point in care. The primary aim of this project was to reduce UTI incidence through standardized education delivered at home health admission. Secondary aims included improving hydration education, strengthening antibiotic stewardship practices, and reducing UTI-related hospitalizations. The project also sought to establish standardized workflows and identify policy gaps to support sustainability beyond the intervention period. The literature review identified 3 consistent themes: UTI risk factors, educational interventions, and prophylactic strategies. Among these, hydration emerged as the most consistently supported and clinically feasible modifiable factor. Overall, the literature consistently supports the use of educational interventions, hydration programs, and nurse-led diagnostic algorithms to reduce UTI incidence and inappropriate antibiotic use in older adults. Evidence also supports potential protective benefits of vitamin D on uroepithelial tissue, and it supports innate immune defense. This is an especially relevant consideration for home health populations in the Pacific Northwest coast. But while vitamin D remained a modifiable risk factor, it was not specifically targeted in this project due to time constraints within the implementation period. This project was guided by a Plan, Do, Study, Act framework supported by focus principles. The PDSA cycle was selected because it's well established as an effective framework for quality improvement in real-world clinical settings. Pullett and Beck emphasized that PDSA supports systematic testing of practice changes while remaining feasible within complex healthcare environments. Additionally, Taylor and colleagues highlight PDSA's strength in allowing iterative learning, rapid feedback, and adaptation, which was essential given the workflow variability and organizational change occurring at the project site. Together, these features make the PDSA most appropriate framework for this home health quality improvement project. The focus principles were used because they provided a structured way to operationalize the change process before and during the PDSA cycle. Focus helped identify the specific UTI-related gap, organize stakeholders, clarify inconsistent practices, and understand variation in assessment and education and admission. This approach ensured that the intervention was targeted, workflow appropriate, and grounded in real clinical processes, which is essential for sustainable quality improvement in home health settings. This project used a quantitative quality improvement design with retrospective chart review. The setting was a single home health agency branch in the northwestern United States. This design was used because the intent was to evaluate a practice change using existing clinical data rather than generate generalizable research. Pullett and Beck described this approach as appropriate for quality improvement initiatives focused on practice evaluation and system outcomes within real-world settings. By comparing UTI incident rates before and after implementation of the educational toolkit, this method directly supported evaluation of whether increased hydration and hygiene education at admission influenced UTI frequency, and thereby answering the clinical inquiry question. The project followed structured phases that included planning, staff education, toolkit implementation, and evaluation. IRB approval was obtained as a quality improvement project. A convenient sample of 1,167 adult admissions was included, with 747 pre-intervention and 420 post-intervention admissions. All data were aggregated and de-identified, with no patient identifiers collected for the project. The retrospective design allowed evaluation without disrupting clinical workflows, which was essential given operational constraints. The intervention was a standardized UTI educational toolkit delivered at the time of home health admission. The toolkit included a graduated water bottle and education tailored for patients, caregivers, and catheter status. Education emphasized hydration, hygiene, symptom-based assessment, and antibiotic stewardship. Staff education was delivered to both licensed and non-licensed personnel using evidence-based criteria, including the lobe diagnostic criteria. Toolkit delivery was embedded into existing admission workflows to support feasibility and long-term sustainability. Admission was identified as a pivotal point in care where risk mitigation was most impactful. This slide reflects a baseline admission education used at the project site prior to implementation. While regulatory requirements were being met, these tools focused primarily on broad infection recognition and lacked condition-specific prevention-focused guidance, which contributed to variability in clinician practice. These clinical risk identification tools were developed to reduce diagnostic variability by providing a standardized framework for assessing patient-specific UTI risk at admission. They emphasized hydration status and symptom-based assessment to support consistent clinical reasoning. The lobe diagnostic criteria were incorporated as decision support to guide appropriate urine testing in older adults. Use of this criteria helped clinicians differentiate true infection from ASB and strengthened antibiotic stewardship practices. Please excuse me. My asthma and allergies are out of control these last few weeks. Education was tailored for catheterized patients, non-catheterized patients, and caregivers, ensuring risk-appropriate prevention. Staff education was delivered in small groups over 4 days during the quarterly staff meeting at the branch office. It included a 36-slide PowerPoint presentation that reinforced education and increased awareness of modifiable risk factors, including hydration and vitamin D. This approach supported consistent messaging and clinical alignment across the care team. The data were extracted from existing EHR quality dashboards. Descriptive statistics were used alongside a 2-proportion lower tail z-test with a significance level of 0.05. The primary outcome measure was UTI incidence per admission. A 2-proportion z-test was selected because the primary outcome of interest was a comparison of proportions. Specifically, the proportion of home health admissions associated with documented urinary tract infections before and after the intervention. This test is appropriate when comparing 2 independent groups with binary outcomes. In this case, UTI versus no UTI, across 2 time-defined admission cohorts. The pre-intervention and post-intervention groups were independently sufficiently large and met the assumptions required for a z-test, including adequate sample size to approximate a significance level of 0.05. This statistical approach allowed the project to objectively evaluate whether standardized hydration and hygiene education and admission was associated with meaningful change in UTI rates, thereby directly answering the clinical inquiry question within the quality improvement framework rather than an experimental research context. 27 UTIs occurred among 747 admissions pre-intervention, yielding a rate of 3.6%. This data represents the baseline UTI burden prior to intervention and established the reference point for evaluating post-implementation outcomes. 12 UTIs occurred among 420 admissions post-intervention, yielding a rate of 2.86%. Although the reduction did not meet statistical significance, the trend suggests a clinically meaningful improvement consistent with prevention-focused education. This figure illustrates a reduction in absolute UTI cases following implementation, reinforcing the observed directional improvement. And these charts compare UTI proportions before and after the intervention, visually reinforcing the reduction observed during the post-intervention period. The z-test did not demonstrate statistical significance with a p-value of 0.24. The confidence interval crossed 0. Therefore, the null hypothesis was not rejected. However, from a clinical and quality improvement perspective, the observed reduction represents a favorable and meaningful trend in a high-risk population. Qualitatively, the intervention revealed important workflow and policy gaps, particularly related to diagnostic consistency and stewardship practices. The short implementation period and significant organizational disruptions, including a corporate acquisition and EHR transition, likely limited consistent use of the educational toolkit and reduced overall intervention fidelity. Increased productivity demands may have further diluted measurable impact. Together, these factors likely contributed to the lack of statistical significance despite a clinically meaningful downward trend. The findings of this project demonstrated a reduction in UTI incidence following implementation of the educational toolkit, with rates decreasing from 3.6% pre-intervention to 2.86% post-intervention. While this reduction did not reach statistical significance, the observed trend aligns with existing literature that supports education-based prevention-focused interventions in high-risk older adult populations. When interpreting these findings, it's important to consider the context in which the project was implemented. The intervention occurred during a period of organizational transition, increased clinician workload, and EHR changes, all of which likely diluted intervention fidelity. Despite these challenges, the directional improvement suggests that standardized hydration and hygiene education may contribute to UTI risk reduction when consistently implemented. In relation to the clinical inquiry question, does increased education on hydration and hygiene decrease the frequency of UTI rates over 3 months? The findings suggest that increased education was associated with a clinically meaningful reduction in UTI rates, even though statistical significance was not achieved during the limited implementation period. These findings also highlight the realities of quality improvement work in real-world clinical settings. Unlike tightly knit controlled research studies, quality improvement projects must adapt to workflow variability, competing priorities, and organizational change. In this context, the lack of statistical significance does not negate the clinical relevance of the observed reduction or the value of the intervention. I want to highlight that the project revealed critical insights beyond numeric outcomes. The intervention exposed gaps in diagnostic consistency, antibiotic stewardship practices, and clinician understanding of dehydration-related cognitive changes. These qualitative findings are significant, as they identify system-level opportunities for improvement that may have long-term impact on patient safety and quality outcomes than a single metric alone. Overall, the findings support the use of longer implementation periods, stronger process fidelity monitoring, and ongoing education reinforcement to more fully answer the clinical inquiry question and achieve sustained reduction in UTI incidence in home health populations. Implementing a standardized UTI education process strengthened clinical consistency, improved symptom-based assessment, and enhanced antibiotic stewardship at the point of home health admission. For patients and caregivers, this intervention improved understanding of hydration, hygiene, and early symptom recognition, and it empowered them to participate more actively in infection prevention. It also helped reframe dehydration-related cognitive changes, reducing unnecessary testing, antibiotic exposures, and unwanted anxiety for caregivers. From a broader healthcare perspective, this project demonstrates a scalable, low-cost intervention that can be applied across home health agencies, skilled nursing facilities, and assisted living settings, By embedding evidence-based education into existing workflows, the project supports sustainable improvement without adding significant burden to staff or organizations. At the community level, this approach contributes to better antibiotic stewardship, reduced avoidable hospitalizations, and improved patient safety in a high-risk population. Overall, the project highlights how nurse-led prevention-focused strategies can drive meaningful quality outcomes beyond a single care setting. In conclusion, this project demonstrated that standardized educational toolkits delivered at home health admission are feasible to implement within existing workflows and are associated with a clinically meaningful reduction in UTI rates. Although statistical significance was not achieved during the limited implementation period, the observed downward trend supports the value of these findings and underscores the importance of longer implementation periods and stronger fidelity monitoring to fully evaluate the impact of educational interventions in complex real-world care settings. Despite significant organizational challenges during implementation, including leadership transition and EHR changes, this project reinforced the role of the nurse-led initiative in driving systems-level quality improvement. The findings highlight opportunities to strengthen diagnostic consistency, antibiotic stewardship, and policy development related to UTI prevention in home health settings. If this project were to be expanded or repeated, key modifications would include a longer intervention period, improved tracking of toolkit delivery and caregiver engagement, and integration of additional modifiable risk factors such as vitamin D screening. These changes would support sustained behavioral change and more robust outcome evaluation. As I conclude, I would like to briefly reflect on the impact of the DNP project on my professional growth. This project represents a significant shift in how I approach clinical problems, not only identifying gaps in care, but using evidence, quality improvement science, and leadership principles to design sustainable solutions. Through this process, I strengthened my ability to critically appraise evidence, lead change during organizational uncertainty, and translate research into practice in a way that prioritizes patient safety and system improvement. This project reflects my development as a DNP-prepared nurse and systems-level change agent, prepared to lead prevention-focused, data-driven improvements in home health and beyond. I'm grateful for the mentorship and the support that I've received through this process. Thank you for your time and attention today, and I welcome your questions and discussion. All references listed on these next 18 slides are presented in APA 7th edition format and reflect the evidence integrated throughout the project.